This is something I've become interested in largely as a result of work on diagnostics that we've been doing in Peru for the last decade or so, rolling out diagnostics for drug-resistant TB, which has two consequences that are unhelpful but also important. One is you diagnose lots of people with MDR, which is obviously a good thing, but you also generate a lot more known MDR contacts, and we have to work out what to do with them. And the other is you identify a lot of people using the diagnostic that we used, MODS, you identify a lot of people with isoniazid monoresistant TB, and I'm not going to talk about that at all, but that is another sort of unaddressed problem, and is slightly related to what you do with the contacts of those people as well. So primarily what I'm going to do is talk about the conversations that are going on amongst people who are interested in this problem, rather than tell you anything specific related to ongoing research. And I'm not going to talk about the nature of latent TB infection. Alison's shown that graphic, and that really is the evolving discussion that's going on about that. I'm not going to talk about how we diagnose LTBI, that's been covered already, or indeed what preventive therapy is doing, whether it's sterilising a latent infection or dealing with infections that are acquired during the time you're taking it. And I'm not actually going to talk separately about HIV, because that's all part of the same issue here. This is primarily about considering the weighing up the benefits of giving preventive therapy, and we'll talk about what that means later on, to the contact of an infectious MDR index case. And I'm talking about all age groups here, not just children. So there are a lot of MDR contacts out there, and faced, as Derek would say, in the clinic with these people, what are we going to say to these people about their risk of developing disease, about the risk of developing drug-resistant disease, and what we can do to help them manage that. Above all, what we're trying to do is avoid active MDR-TB, or at least advanced active MDR-TB. So we're all familiar with this idea that drug-susceptible TB has a relatively short treatment course of 6 months, generally pretty well tolerated in the most recent WHO report, and globally that's an 86% treatment success. Whereas MDR is a completely different entity. The global success rate for treatment is 50%. That's 50% of people either cured or completing treatment. So it's not just that's not a cure rate. And it is thousands and thousands of pills and months of injections. And patients don't tolerate this treatment well. And at the moment, that means at least 18 months, often more than 20 months of treatment. I think there will be disappointment in the global TB community if the current guidelines that are being developed, updated by WHO, don't endorse, or at least for some way include the Bangladesh regimens, the shorter regimens of 9 months. But even at 9 months, the treatment is toxic and is poorly tolerated. So we want to try and avoid MDR, and I think we all would agree that that would be a thing worth preventing if we had the tools to do so. So let me take you to Peru. This is a typical family in Peru. Lucho becomes sick in July 2007, and within a month, and because of obviously the brilliant diagnostic rollout there, he's diagnosed with MDR-TB, and he starts his treatment. Now, just for those of you who haven't done a lot of clinical management of MDR-TB, there are guidelines for this, and WHO has a guideline. It has a companion handbook for the guidelines, which is your go-to place to develop your regimen. And just to give you a sense of how complex the management of MDR-TB is, you have to get to page 86 of this 450-page companion document before you can start building Lucho's regimen. So this is not a simple thing to do. Lucho starts his treatment. He gets the usual torrential diarrhea with PAS. He starts losing his hearing, so he stops his injectable early. But despite all of this, he converts his culture within 3 months, and a couple of years after his first diagnosis, he's declared cured. Well done, Lucho. Pablo lives with Lucho. Pablo's Lucho's brother, and Juan is his other brother, and Maria and Sonia are his 2 sisters. So what are we going to do? What are we going to say to these 4 people, young adults, economically active, in 2007? So everyone put your hand up. Everyone in the audience put your hand up. Okay. Keep your hand up if you're going to offer them some sort of preventive therapy. Oh, lots of people. I'm fascinated to know what people are going to give them. Okay, fine. All right, let's see where we go with that. So let's go to the companion handbook and see what that tells us we should do with these 4 individuals. So luckily in the companion handbook on chapter 1 is all about prevention of drug-resistant TB, and you can't read that, I'm sure, but essentially there's nothing in there about what you should do with the individual with drug-resistant TB. It's all about preventing the emergence of drug-resistant TB in people who are drug susceptible at baseline, or it's about infection control, stopping transmission. But there's nothing in this handbook that gives us any sort of steer on how we should manage these contacts. So you want to hear how the story goes? Well, Pablo unfortunately starts coughing midway through Lucho's treatment. He's got smear-positive disease, and it is MDR, so he also goes on to MDR treatment. And his sister Maria develops TB as well, but she's actually got a different strain. She's got fully susceptible TB. And that discordance in the strains that occur within households in high-burden populations, where there's lots of the force of infection is not just in the household, but is in the community as well, is an important consideration when you're thinking about what preventive therapy you might give to household contacts. You've got to bear in mind they've been exposed to other strains. So the question is whether or not Pablo and Maria's disease could have been avoided with preventive therapy. And perhaps the two crux questions for preventive therapy being successful is firstly that the organism with which one is latently infected should be susceptible to whatever agent or number of agents we choose. And secondly, that ideally that drug should be one that kills non-replicating organisms. And Alison's alluded to the fact you wouldn't have started with isoniazid if you'd known how it worked years ago. Well, now that we know about the way drugs work, we can probably be a bit smarter about choosing our drugs and try and aim for drugs that might kill non-replicating organisms, if that's what we think latent infection is. And then we need to take account of a number of other things. So firstly, the likelihood that of those four siblings, two of them would develop secondary disease. And by secondary disease, I mean disease that's related to the index case. So Maria's case was not secondary disease. She developed TB, but it wasn't secondary to her exposure to her brother. And I'll show you some data that suggests that that's slightly less likely in contacts of index MDR cases than drug-susceptible cases. We want to give therapy that is not highly toxic, so that contacts are able to take and tolerate the medication. And ideally, that should be a short duration therapy with as few drugs as possible. And then we need to take account of the fact that actually stopping the development of a single case of drug-resistant TB actually has a significant impact upon transmission, because none of those potential future contacts will have been exposed if we can prevent a case of MDR arising in someone who may have been destined to develop it. And then these two things at the bottom, minimizing the risk of resistance amplification. I think I'm going to sort of put that to bed, really. This question about whether isoniazid preventive therapy generates isoniazid resistance does not really seem to be a big issue, and I think that probably the same could be said as long as you've given it to healthy people, not to people who've got some sort of poorly symptomatic disease, or not to people who've not been adequately screened. I think that's a sideshow that we need to sort of get away from. And then the question is, well, if we don't give preventive therapy, for all of those who put their hands down, what are we going to do? What's the alternative? What can we offer to these contacts? So the good news is that there are 3 trials that I know of that are either underway or about to get underway within the next year, looking at this question with regard to preventive therapy. You can read them for yourself there, but 2 of them are in all contacts, so not just under 5s, but in adults and children. And the regimens that people are interested in are quinolone-based, and primarily that means levofloxacin, or the use of the new drug delamanid. And all of these are looking at giving treatment for 6 months with variable amounts of follow-up, anything between 18 and 30 months of follow-up from the initiation of treatment. Only one of them so far has been registered on the clinical trials registry, which suggests that the others are still not quite ready to go and are still having some discussion about what the trial should actually look like. But those are the studies that are underway, which is great and encouraging. And is good to know. But of course, these studies won't report until at least 2020. So what are we going to do in the interim? Just a couple of quick points about those studies. One of the concerns that has been raised for a long time in this discussion is whether or not we should be using fluoroquinolones, particularly in young children. I think there's now sufficient evidence that the benefit in this setting, if there is a benefit in preventing treatment, certainly the benefit in terms of treatment of drug-resistant disease, outweighs any risk. So don't give fluoroquinolones to your beagles, but apart from that, we think it's fairly safe to use in children. So let's not talk about that any further. And then Alison's already mentioned this, I think, revolutionary regimen for latent TB infection in people who are presumed to have drug-susceptible disease. This is a regimen that takes you from 270 doses to 12 doses of treatment and gives you the same efficacy. So one of my disappointments, I suppose, with this table is that the treatment is for 6 months. There's an awful pill burden here. And maybe we need to be a bit more bold and think about giving slightly more conservative treatments, albeit with 2 drugs. Obviously not either of these 2 drugs in MDR. But if we can get clearance of latent infection with 12 doses of one regimen in this setting, maybe there are 12-dose regimens we could be looking at for MDR. And that would be fairly revolutionary. So that was the question that I was asking at the start. And really the question is, what are we going to do now while we await the results of those trials and whether or not those trials give us the data we want? And so with regard to that, our sort of guidance really comes from this meeting, which was convened by James Seddon in the audience, who's one of the architects of this group, and colleagues in Harvard Medical School, really to bring together people who had an interest in the subject to look at what evidence was available and come up with some sort of guideline to give people some idea of how to make a decision about what to do with their patients. And so the proceedings, these are both available online. The proceedings are available online, which describes the meeting that went on in Dubai in April, and then a policy brief came out in November last year. And I'm just going to run through some of the recommendations and some of the evidence behind them, and then perhaps suggest some alternatives. So essentially the policy brief came out with 7 principles, and I'm going to run through these, the sort of key ones one by one. So the first thing was this sense that the language possibly needs reorientating. So we're using this term prophylaxis, preventive therapy, we're talking about latent infection, and actually that gives a sort of sense that it's maybe not as important as it should be, and maybe we should start talking about treatment of TB infection and post-exposure management of household contacts. And I like this post-exposure management of MDR contacts. It makes it an active process. So I think that's a helpful proposal. Clearly, we should be identifying all household contacts and evaluating them for active disease. That goes without saying. But then the next bit, I think, is more contentious and certainly generated a lot of discussion. And this was that we should be offering preventive therapy for TB infection if the index case was assumed or not confirmed to have fluoroquinolone resistance for at least under 5-year-olds and people with immunosuppression, which is largely people with HIV of any age. No need for testing for latent infection. That seems very reasonable. That's been an obstacle to IPT and certainly doesn't seem to be a useful guide in this setting. But the treatment should be given for 6 months and should be directly observed. Fluoroquinolone-based, either moxifloxacin or levofloxacin, or, so either fluoroquinolone monotherapy or fluoroquinolone combined with either ethambutol or ethionamide if you know the drug susceptibility profile of the host case. So that's the recommendation. I just want you to understand where those recommendations have come from. I think it's helpful to have recommendations. We're in a vacuum of recommendations. We need some sort of guidance, but it's important to understand the context. So there are around about a dozen trials. This is a table in the guidance document, which you can look at yourself. You're not supposed to be able to read it from here. But this is essentially observational data on 650 patients, of whom a third received 3 agents for 6 months. You could almost say that's almost a treatment. A third received pyrazinamide-containing regimens, and there was high toxicity with that, so any regimen that contains pyrazinamide is not part of the recommendations. And what that really means is that these recommendations have been made on the basis of about 256 patients globally. So it's just important to understand, and I know that we constructed our MDR regimens based on expert opinion for many years, but it's important just to take into consideration that this is a relatively small, relatively thin evidence base. This, however, is understandably one of the studies that has really propelled an active preventive therapy approach in those who are very keen on it. And this is an outbreak. There were actually two separate outbreaks of MDR in the state of Chuuk, which is one of the states of the Federated States of Micronesia. This is out in the Pacific. Is the state that has 50,000 people. And of the two, from the 2 index cases, they identified 119 contacts, 15 of whom refused any therapy at all, and 104 initiated therapy. And amongst those who initiated therapy, and there was quite a decent follow-up period and quite reasonable case ascertainment, about 85% case ascertainment, there were no cases of active MDR-TB. And there were 4 different preventive therapy regimens. This is not very clean data, but nevertheless, it is what it is. Of the 15 who refused to take preventive therapy, 3 of them developed MDR. Now, clearly, they weren't randomized to refuse. They were offered therapy and they refused to take it. So these may be, you have to bear in mind these are observational, not randomized data. And there were 15 additional cases of MDR-TB amongst people who had not been identified as contacts, people who didn't seem to have any link to the 2 index cases. And we don't know how many that group of unidentified contacts is. But this data is certainly cited as highly suggestive that you can deliver preventive therapy. Clearly, this was a massive undertaking, even in a population of 50,000 people. But this is interesting, that there was no active MDR amongst the 104 who initiated. That's not entirely true. 15% of these did not have an outcome ascertained. So it's entirely plausible that 15 people developed MDR-TB and died quietly in a corner. But that's not believed to be the case. So, is there an alternative preventive therapy? Because we have no way really of knowing if the contact is infected with the same strain, or indeed whether our agent has activity against these latent, non-replicating organisms. It's clear that it's worth identifying all household contacts. It's worth evaluating them for active disease, and this is just really to show you just how worthwhile it is going into households. So this is data from Louis Grandjean's PhD. He was my PhD student in Peru for a number of years, and we argued for a long time about this fitness cost that was alluded to earlier from the acquisition of drug resistance, with me saying I don't think it can be that important, there's lots of drug-resistant disease around, and him saying no, it's really important. And what he demonstrated was that the incidence of active disease, of active second case disease in households of drug-susceptible index cases was 4,000 per 100,000 and was much lower in the contacts of MDR index cases, but was still extraordinarily high, was still 20 times the rate in the general community. So it's well worth going into households. And so, in his survival curve, he clearly showed to me, and then had the audacity to show other people that he was right, that contacts of drug-resistant TB seem to have a lower rate of incident secondary TB than the contacts of drug-susceptible TB. It's still a high number. It's not sufficiently lower that we shouldn't be doing anything about this. I've talked about the treatment that should be this group have suggested we should be offering for TB infection, but let's just look at the inter-house concordance. So this is data from the Harvard group showing that approximately 90% of their contacts in whom a drug susceptibility test was available had an MDR strain. Louis had an earlier study that suggested it was about 70% concordance of the household contacts of index cases with MDR. And then when you look at all the data together and you pull out those that have got more than 10 cases, sort of randomly, because much fewer than that, it's difficult to make much sense of it. Savita Shah did this as a clinical infectious disease review. In those studies which have more than 10 DST pairs tested, the concordance really varied. But if we say on average it was about 70%, that means about 30% of secondary cases in multi-drug-resistant households will not have MDR-TB. So that's just worth playing into the conversation about whether or not giving quinolones and ethionylamide for 6 months is the right thing to do. So there are lots of questions, and I haven't really got many answers for you. I really just wanted to lay out the sort of state of the conversation at the moment. How to screen contacts and how to give preventive therapy are pretty much the sort of same conversations we have for IPT. How to monitor adverse effects and breakthrough disease, the same sort of thing. Who we should be considering for latent TB infection treatment in the MDR contacts is again up for grabs. And whether or not this should be a single standardized regimen or should be personalized according to the drug susceptibility profile of the index case is still unclear. Most of these regimens that have been in this table here, sorry, I should have mentioned this at the time. Most of these regimens here were of the order of 6 to 12 months. So this is not short course treatment. So, I thought I'd taken this slide out. I'll leave it in. Okay, so let's imagine, this is a very simplistic discussion. Let's imagine we've got 100 contacts of MDR index cases. If we say that 10% of them are going to become cases during the course of their lifetime, and let's imagine that all happens in the first couple of years, then 90 people will not be cases ever. They're not destined to become cases. And as we've heard, we've no way of distinguishing between those two groups, and that would really be a test that made a difference. But these 90 cases are people who, if we're going to give contacts preventive therapy, these are people who will be getting preventive therapy without a need for it. But even amongst our 10 cases, if we say 70% of them will be concordant with the index case, then only 7 cases will be getting the benefit of preventive therapy, even if we assume 100% efficacy for our treatment. That is a bit simplistic, and I will find that hard to defend if you ask me a question about it. Okay, but if we don't give preventive therapy, then what are the alternatives? Well, I would advocate that I think there is an alternative. And our sort of standard view of a patient with MDR-TB being someone who's failed 3 or 4 different cycles of regimens and has come with massively destroyed lungs and a high bacillary load may not be anything like the patient who is a household contact who develops some early symptoms, who we diagnose because we've got them under close surveillance. So how about some regular review for a couple of years after we start the index case on treatment, because we'll be in and out of that household, or at least have contact with that household anyway. How about regularly doing a sputum culture or an expert, or it doesn't have to be 3 monthly, it could be 6 monthly. That would give us the opportunity for an early diagnosis, and therefore one assumes a lower bacillary burden, less destroyed lungs, and we'd have a strain which we could do drug susceptibility testing on early, were it available, and therefore one imagines a higher likelihood of treatment success. Maybe these are the people who would benefit from the Bangladesh regimen. And that would avoid giving lots and lots of people preventive therapy that would never really need it. The counter-arguments, which are all completely valid, is that's quite hard to do. People get lost to follow-up. They're well. Why would they hang around? It's you're asking a lot of your laboratory. And actually, in the under 5s, the ones you're really worried about who will develop miliary disease or TB meningitis, seeing them every couple of months or doing a culture every 3 months is just going to miss the rapid development of progressive TB in kids. And finally, in this point, we have relatively recently had a look at this question of whether early treatment improves your clinical outcome on MDR treatment, and we haven't yet been able to find any evidence that that's the case. Now, intuitively it makes sense, but there isn't any evidence at the moment published that supports that assumption. So this is my second to last slide, I think, Ryan, so give me a second. So I would argue that, and I don't think there's much contentious about this, that whatever we do, whether we give preventive therapy or don't give preventive therapy, we need to be registering every single contact of an MDR index case in some sort of registry that is harmonized across country, so everybody's collecting broadly the same amount of data, or the same data points, and so that we learn from every single MDR contact, whether they're given preventive therapy or not, what their outcomes are. And in that way, we can rapidly grow a large observational data set that has meaning across the globe. Moreover, national TB programs can monitor their programmatic management of drug-resistant TB by how many of these contacts they manage to follow for 2 years, how early they diagnose them, etc. And we're working towards developing that at the moment. So in summary, active management is required of these intradomiciliary contacts, not a passive approach. The evidence-based preventive therapy is currently thin, but there are some recommendations, and as long as you understand the background to those recommendations, then they seem not an unreasonable way to go if you want to give preventive therapy and the patient wants to take it. The RCTs are underway, but we're some way from learning from those. But in the interim, firstly, don't worry about fluorocorneal resistance and don't worry about amplification of drug resistance. They don't appear to be major concerns. There is some evidence that preventive therapy has been used successfully. A large number of kids have been treated with preventive therapy in South Africa, but preventive therapy in South Africa often means 2 or 3 drugs or 3 or 4 drugs for 12 to 18 months. It's not quite the same as giving 1 or 2 drugs for 6 months. An alternative is close observation with early diagnosis and treatment, and whatever we do, we should be keeping all these contacts under surveillance for 18 months, 12, maybe 24 months to contribute to our knowledge base. So let's go back to the familiar Marcelo and see if we still all want to give preventive therapy. So hands up again. And keep your hand up if you still want to give preventive therapy to all 4 of these. Almost nobody's changed their mind. Right, okay. Well, there you go. Thanks very much.